Langer's lines, which are also referred to as lines of skin tension. This is point number 1. They are referred to as lines of skin tension. Number 2, what do they correspond to? They correspond to the orientation of collagen fibers in the dermis. So their orientation is what Langer's lines corresponds to. Why do we need to remember these lines? Because these lines are important in the context of a surgery, wherein a surgical incision is always put along these lines. So surgical incisions are always put along these lines when the scar heals well. The second important types of lines are Blaschko's lines. Now what do they represent? They are the epidermal cell migration which happens during the embryologic development. So please remember, students, study is all about picking up the keywords. So embryology is the word for Blaschko's lines. Collagen and skin tension is the word for Langer's lines. So this is how we remember. How do we identify these lines? You can see that they are V-shaped on the upper spine. So we can see here that they are V-shaped on the upper spine. On the abdomen, they are S-shaped. On the scalp, they are going to be spiraled. This pattern is known as spiraling. Next, we move to the applied aspect. Name one important disease which follows Blaschko's lines in dermatology. So it is a pediatric disorder. Anybody who's interested in taking pediatrics in the future should definitely be looking at this disorder, which is called incontinentia pigmentae. So incontinentia pigmentae is an X-linked dominant disorder, and the distribution of lesions in incontinentia pigmentae is going to be along the Blaschko's lines. Let us now move on to a clinical test which is called as endoscopy. So what do we do in endoscopy is we take a glass slide and we press it over the skin lesion. So here we can see here endoscopy is being performed. A glass slide is being pressed over the skin lesion. Why do we do this test? Predominantly is to distinguish between two conditions, erythema and purpura. Now erythema, what happens is it is characterized by vasodilation. In purpura, what happens is RBCs are moving outside the vessel. So this is referred to as extravasation of RBCs. Extravasation of RBCs. So what will happen in erythema? If you take a glass slide and press it over it, what will happen is you are pushing the blood out. So this is called as blanching response. Whereas in purpura, what has happened is the RBCs have gone outside the vessel, they've got degenerated and they've stained the vessel wall. So now, in spite of pressing the lesion, the stain persists. So that's why it's called non-blanching response. So here we can see in the image that in spite of pressing the glass slide on the lesion, redness is persisting. That's why this is a feature of purpura. So basically for the exam, erythema blanches, purpura does not blanch. Now one more important use of endoscopy is in the demonstration of apple jelly nodules. So here we can see the examiner has in the first slide pressed the lesion, and here you can see the development of a yellowish brown color. So this is before pressing, and after pressing the lesion you can see this yellowish brown color which you're getting. This represents apple jelly nodules. So this basically happens due to the presence of dermal granulomas. This happens due to the presence of dermal granulomas. There are three important conditions where we get apple jelly nodules. Number 1 is lupus vulgaris, number 2 is sarcoidosis, and number 3 is cutaneous leishmaniasis. So three important disorders where you get apple jelly nodules. Next we move on to dermatological investigations. First is Woods lamp examination. Now Woods lamp examination is a non-invasive diagnostic tool wherein what are we doing is we are examining the skin under UV light. So very, very important. Now what is important about this Woods lamp is that Woods lamp is going to emit a wavelength of 365 nanometers, which is roughly the number of days in a year. Now how is it able to emit this wavelength is because it has a filter which blocks out all other visible light. And this filter is made up of number 1 barium silicate, number 2 9% nickel oxide. So these are two important points to remember here. Let us now look at the different colors in the context of Woods lamp examination. The first color is going to be in the context of erythrasma. Now, what is erythrasma, students? It is a corynebacterial infection. It's a corynebacterial infection. In erythrasma, the color which you get, as you can see in the picture, is coral red fluorescence. So eryth means red, so we can remember coral red fluorescence. The second color is in relation to pityriasis versicolor. Pityriasis versicolor is a superficial fungal infection of the skin, and here the color which we get is obviously a little bleak in the picture, so it is to be remembered as yellow color fluorescence. Now we go to color number 3. We are talking about Tinea capitis, wherein the dermatophytes have involved the scalp hair. So two important species. Number 1, microsporum species, we get blue-green color. And in Trichophyton schonleni, the only species of Trichophyton which shows a fluorescence, we get a dull blue color. So we have to memorize all these colors. And lastly, in a disease called vitiligo, we get milky white fluorescence. So just to repeat, in erythrasma we get coral red, In pityriasis versicolor, we get yellow, microsporum species, blue-green, trichophyton schondlini, dull blue, and in milky white fluorescence is a feature of vitiligo. Now we go to dermatological therapy.
Lines, Langerhans, Blaskos lines, skin tension, embryological, dermatological investigation, diastrophic pressure over skin, blanches, non-blanches. If blanches, then it is the erythema, and if not blanches, then it's purpura, apulgally nodule, branches, brownish color, nodule. Due to dermal granulomas, lupus vulgaris, sarcoidosis, and cutaneous leishmaniasis, Boots limb examination is diagnostic. Skin under 365 nanometer wavelength, filter barium silicate nickel oxide. This is erythrasma, erythra, red, coral red. Pityriasis versicolor, skin infection, fungal. Pityriasis versicolor yellow. Microsporium blue-green, trichophyton dull blue, and vitiligo milky white, yes.
So first we're talking about cryotherapy, where we use an agent called liquid nitrogen. It has a temperature of minus 196 degrees Celsius. How does it work? It basically is going to be producing freezing effect. So it freezes the tissue. Most important indication of cryotherapy in dermatology is the treatment of wounds. Next, we want to phototherapy. Now, what is phototherapy, students? So, when you say photo, light should come to our mind, and we're thinking of ultraviolet radiation over here. So, two important forms of phototherapy. Number one is NB-UVB. Now, NB stands for narrowband UVB. Now, this narrowband UVB, the wavelength is 311 plus or minus 2 nanometers. So, please remember, students, that 365 nanometers is for wood slab examination, which I already told you. 311 plus or minus 2 nanometers is for NB-UVB. Now, what is UVA? Now, UVA is made up of two things.
Soralin and
stands for soralin. This is a photosensitizer. So first we use soralin in the form of topical or oral soralin, and after some time we are going to expose the patient to ultraviolet A radiation. This results in better uptake of the UVA once soralin has been used prior. Three important uses of phototherapy in dermatology. Number one, we have psoriasis. Number two, we have vitiligo, and number three, we have atopic dermatitis. So three important uses to remember. Next we move on to appendices and disorders. In appendices,
agent UV radiation types NB UVB, narrowband UVB, transubder plus minus blue, soralin followed by UVA. Cryotherapy agent liquid nitrogen, temperature minus 196, physics tissue, example watts में body cry, watts में baby cry करे. Okay. Indication of phototherapy is psoriasis, vitiligo, atopic dermatitis.
and disorders. Number one, let us learn to label the various appendices of the skin, which was asked in the PG 2024 examination. So first we see this gland here, which is directly opening onto the skin surface. We call it as eccrine sweat gland. Eccrine sweat gland. Second B, we see another sweat gland which is opening into the hair. So the sweat gland which opens into the hair is called as apocrine gland. Apocrine gland. The third important structure is a lobulated gland which is opening into the hair. We call it as sebaceous gland. As I mentioned, it has a lobulated appearance. And lastly, we see this muscle here, which is attached to the hair. This muscle is called as the erector pili muscle. So this is the erector pili muscle, which basically divides the hair into two segments, the upper segment and the lower segment. Let us take up the most important topic in appendices and disorders, which is alopecia. Now, what is alopecia, students? Alopecia means a loss of hair. Alopecia is broadly divided into two categories: non-cicatricial and cicatricial. Now please remember, students, the word cicatrix means scar. So non-cicatricial alopecia is also called as non-scarring alopecia. Cicatricial alopecia is also known as scarring alopecia. Now non-cicatricial alopecia will be taken up first. There are importantly four categories over here: patchy, diffuse, pattern and systemic disease. So these are the four categories of non-scarring alopecia. Under patchy, we have four important disorders. Number one, alopecia areata. Number two, trichotillomania. Number three, tinea capitis. Number four, four important disorders which we need to keep in mind. Under diffuse, we have to remember the word effluvium.
Alopecia areata patch. Alopecia areata trichotillomania and tinea capitis. Secondary syphilis. Alopecia areata trichotillomania, tinea capitis. Hey, what's this? Oh. trichotillomania and negative secondary syphilis.
Equilibrium means loss of hair.
Enagum.
So we can lose hair, number one, in the anagen phase, which is called as anagen effluvium. We can lose hair in the telogen phase, which is telogen effluvium. Next, we move to pattern. Under pattern, you have to remember the genetic cause, which is androgenetic alopecia. And lastly, under systemic disorders, we remember SLE and thyroid dysfunction. So these are broadly the different disorders and the four headings under patchy, diffuse, pattern, and systemic disease. Now, here I would want to finish anagen effluvium and telogen effluvium. Now, anagen effluvium generally results due to the use of chemo or radiotherapy. So secondly to chemo or radiotherapy, the hair fall which you get is called as anagen effluvium because it targets the rapidly dividing or the growing cells. Telogen effluvium is seen secondary to severe systemic stress. Severe systemic stress is responsible for telogen effluvium because after stress what happens is this premature transition of the hair from the anagen to the telogen. We know once the hair goes into telogen, it is going to remain there for 3 to 4 months. That is why 3 to 4 months after the stressor, the hair fall which we get is called as telogen effluvium. Let us take up the most important disease, that is non-scarring alopecia, which is alopecia areata. Now, alopecia areata is an autoimmune disease. It's an autoimmune disease. And what does it target, students? It is going to target the anagen hair bulb. It targets the anagen hair bulb. How do we identify alopecia areata? Now, alopecia areata, we can see the image over here. We can see that it's a well-defined, circular, smooth patch of complete hair loss. So please remember, students, the three keywords. Number one, it's well defined, it is circular, it has a smooth surface, and it has complete loss of hair patch. Our diagnosis becomes alopecia areata. And in the margin, if we examine many times, we can find a hair like this. We can see the distal end is broad and the proximal end is tapering. So we can see in many places the distal end is broad and the proximal end is tapering. This named hair is called exclamation mark hair because the hair looks like this. Next, we want to the nail examination in alopecia areata. We should examine the nails. Here we get something called as pitting. The pits are described as fine, regular, superficial pits. Fine, regular, superficial pits. These pits are also referred to as geometric pits. That's a geometric pattern. Let us now move to the treatment. The treatment of any autoimmune disorder has to be steroids. So please remember, students, if it is a localized disease, we can inject steroids. We call it as intralesional steroids. The steroid that we use here is triamcinolone. Triamcinolone. And for extensive disease, we want to use systemic steroids. We move to the second condition under patching, which is trichotillomania. Now, what is trichotillomania? Trichotillomania is an obsessive compulsive disease wherein the patient possibly gets the urge and plucks out his own hair. Now, how do we distinguish this condition from alopecia areata? Please remember, students, in alopecia areata, there is complete loss of hair within the patch. Here, there is incomplete loss of hair within the patch. Point number one. Point number two, try to pluck your own hair out. When you try to pluck your hair, is it a painful process or a painless process? This is painful, isn't it? So what happens when we try to pluck our hair out? There will be bleeding. And this bleeding is referred to as perifollicular hemorrhage. This bleeding is referred to as perifollicular hemorrhage.
Intralesional transcendental opposite and extensional systemic steroid opposite. Trichotillomania, mania for psychic persons. Health correction. क्या है
range. And this trichotillomania can be associated with the next stage wherein the patient might eat one's own hair. So this is called as trichophagia. Trichophagia means pathological hair eating. Unfortunately, we know that hair cannot be digested by the stomach, so it forms a mass there. This is called as trichobezoar. So why we need to remember about trichobezoar? Because this is responsible for intermittent obstruction at the gastric outlet. So this is what we need to remember is the association of trichotillomania. We move on to the next condition, which is called androgenetic alopecia. There are two important components. Number one, there is androgen, which are the sex hormones. Number two, there is a genetic factor. So how do men lose hair in pattern hair loss? Number one, this frontotemporal recession. So we can see here the frontotemporal recession which is happening there. Number two, there is a balding of the vertex. So point number two is this balding of the vertex. How do women lose hair? Please remember, students, in women, the frontal hairline is generally maintained. So please make a note that the frontal hairline is generally maintained in women, and this diffuse thinning of the hair over the central scalp. Diffuse thinning of the hair over the central scalp. What is the treatment of androgenetic alopecia? Number one, we have minoxidil. We generally use 2% in women and 5% in men. One more important drug, which is important for pharmacology as well, is finasteride. Now, what does finasteride do? We generally use it in men, and it is a 5-alpha reductase inhibitor. 5-alpha reductase enzyme is responsible for the conversion of testosterone to dihydrotestosterone, which is a more potent form of testosterone. This enzyme is blocked by finasteride. So please keep this point in mind that finasteride is a 5-alpha reductase inhibitor, due to which the dihydrotestosterone levels decrease and it helps the disease process. Next, we move on to the classification of scarring alopecia. We have 4 categories to remember. Number one is papillosquamous. Number 2 is granulomatous. Number 3 is connective tissue disease. Number 4 is infections. So under papillosquamous, we have the most important disease here is lichen planus. Under granulomatous, there's a multisystemic non-infectious granulomatous disorder. You want to go for it? Yes, we call it as sarcoidosis. In connective tissue disease, we have DLE and we have the discoid lesions of SLE. Lastly, under infection, we are going to be talking about tinea capitis inflammatory type. So next we move on to this topic, which has been asked repeatedly in the exam, frontal fibrosing alopecia. Please remember, students, it's a variant of lichen planopilans. So that means it is lichen planus, which is involving the hair follicle, and this is going to be producing scarring alopecia. So we can see the involvement, which is the frontotemporal involvement here. So you get a band-like alopecia in the frontotemporal area. We can see in this image over here. Very important is you can see the presence of mannorosis. So we can see associated mannorosis, which is there in frontal fibrosing alopecia. It is a type of scarring alopecia repeatedly asked in the INICET examination. We now move on to the discussion of sweat glands. So under sweat glands, first we have the eccrine glands, which produce sweat. The mode of secretion is referred to as merocrine. Now merocrine means, we can see here, during the process of the secretion, the cell border remains intact. So intact cell border. And what is the name of the disease wherein the eccrine sweat duct gets obstructed? We call it as miliaria. So blockage of the eccrine sweat duct is referred to as miliaria. Now we go to the apocrine glands. Now apocrine glands basically produce body odor, and the mode of secretion is called as apocrine. Now apocrine, we can see, students, apo means apex of the cell. So here apex of the cell is pinched off. We can see in contrast to mirroring that here the entire apex of the cell is pinched off, and here the blockage of the apocrine sweat duct is referred to as apocrine miliaria. Now this apocrine miliaria is also referred to as pox or dice disease. Pox for dice disease. Now, apocrine miliaria, which I told you is called as Fox-for-Dice disease, is characterized by the presence of pruritic, skin-colored papules. It's a very itchy condition which looks but skin-colored. It's not generally erythematous, and then the sites here are going to be the axilla and the areola of the nipple. So these are the important sites to remember here. Now we have a topic called as ectopic sebaceous glands, and ectopic sebaceous glands are basically those glands wherein sebaceous glands are not associated with hair follicle. So under sebaceous glands, we have number 1, the pilosebaceous unit. Number 2, we have the ectopic sebaceous glands, meaning the sebaceous glands are not associated with hair follicles. Now here, a repeatedly asked question is the presence of these yellow color micropapules, which is called as Furdice spots. So please make note, students, that the yellow micropapules, which are seen over the buccal mucosa and the upper lip, is getting the name of Furdice spots. Next, we move to acne vulgaris. Now, acne vulgaris is a chronic inflammatory disease which targets the pilosebaceous unit. I've already told you. Pilo means hair, sebaceous means sebaceous gland. So, this is the other variety of the sebaceous gland that we have. The microbe which is implicated has been asked in the exam. It is called Cutibacterium acnes. The old name for this condition was Cutibacterium acnes. Now, what type of lesions do we get in acne? We get different types of lesions. We call them as polymorphic skin lesions. So let us now proceed with the grading of acne, because grading becomes important in the context of treatment. In grade 1 acne, we have the characteristic lesion which is called as comedones. So here we can see we have an open comedone. You can see this is called as an open comedone. You can see it's black in color. And here we can see some closed comedones which are white in color. And always remember, students, the best drug for a comedone is retinoids. So two important retinoids which we should remember is number 1, tretinoin and adapalene. One more thing to remember, these comedones, the open comedones and closed comedones, these are the special lesions of acne. So what do you mean by special lesions, students? Special lesions are the specific lesions of a particular disease. Next we move to grade 2. In grade 2 acne, the patient predominantly has these papular lesions. So that is predominantly papules. In grade 3, we have predominantly pus lesions. So we see a lot of pus lesions that the patient is having. So we call it as pustules, which are predominating here. And the most severe form of acne is the grade 4 acne. So you can see in the picture the presence of multiple nodules and cystic lesions. So we call it as nodulocystic acne. So it's called nodulocystic acne. The drug of choice for this condition is isotretinoin. Please remember, students, that isotretinoin is an example for a oral retinoid. Now many students confuse. Please remember, students, tretinoin is topical, isotretinoin is oral. This is something which we should remember for the exams. Now the other name for isotretinoin is 13-cis-retinoic acid. This has been asked in an FMG exam, so we should remember this point. The most common side effect of using isotretinoin, it produces destruction of the sebaceous glands, it produces dryness. It is very visible on the lips, so we call it as cheilitis. And 3 important investigations which we need to monitor for. Number 1, it can produce increased triglycerides and total cholesterol. So this is number 1. Number 2, we have LFT for hepatitis. Very important, while counseling the patient, please remember the patient shouldn't get pregnant because the pregnancy categorization is X. It is a teratogenic drug. It's a teratogenic drug. That means it can produce fetal malformations. Now, very important to remember, students, which drug is not used in the management of acne. Please remember topical steroids. Topical steroids, for that matter, can induce acne. So very, very important. Keep in mind, when you use some cream on the face, it should not be a steroid. It can induce acne. Next, we move to this question which was asked in the exam. A 35-year-old obese female patient with acne is not responding to antibiotics as well as oral retinoids. So usually at 35 years, we do not get, isn't it? We do not get acne generally at this age. Obesity is mentioned and it's non-responsive to the best drug in acne, which is oral retinoids. That means we should look for something else, look for hormonal acne. And in the context of hormonal acne, we have to remember a syndrome called as Saha syndrome. Why do we remember this syndrome? Because Saha syndrome is going to reflect cutaneous changes of hyperandrogenism. So S stands for seborrhea, A stands for acne, H stands for hirsutism, and A stands for androgenic alopecia, early onset. So Saha syndrome is something which we should look in our patients, especially when they come with late onset of acne. Next, we want to condition called rosacea, which is a chronic inflammatory facial dermatosis. So
Saha syndrome. Seborrhea, acne, hirsutism, and androgenetic alopecia. Cutaneous changes of hyperandrogenism. Rosacea म्हणजे गुलाबी.
most important differential for this is acne gaps. So the most important size is rosacea usually comes on the center aspect of the face, so central facial areas. The triggers are going to be
differential is equal to acne vulgaris chronic inflammatory facial dermatosis, central convexity of face, trigger sunlight, spicy food, alcohol, hot beverages. Okay, erythrotelangiectic type. Morphology is erythrotelangiectic type, flushing plus telangiectasia, multiple dilated body. Papular type, and phymatous type, potato nose, rhinophyma, potato nose, chicken skin over nose, irregular surface, nodularity, sebaceous gland,
sunlight, spicy food, alcohol, and hot beverages. So these are the important substances and the triggers which can produce vasodilation. And there are important morphologies we need to remember for rosacea. Number one, you get flushing. You see this redness which is there on the face, so flushing. You also get telangiectasia. So you can see these multiple dilated blood vessels. So we have a dermoscope in our department so that we can clearly visualize the presence of these dilated blood vessels. Number two, you have the next variety. It's going to have papulopustules. So here we can see in the picture the presence of multiple papules and pustules. So this is yet another feature we need to remember. So this is where it becomes confusing to distinguish acne from rosacea. Lastly, we move to the variety which is called as phymatous type. Now, phymatous type is also referred to as a rhinophyma, also known as potato nose. So here we can see the skin over the nose is thickened. Point number one. Point number two, surface irregularities. Point number three, what is the pathology in rhinophyma students? Here, it is the sebaceous gland which shows hypertrophy and fibrosis. So this is a very frequently asked question. Even in EAT, please remember that rhinophyma is going to be involving the sebaceous glands where there is hypertrophy and fibrosis. Now, what is the differential diagnosis? I already mentioned to you, it's going to be acne. But please remember in acne, we have comedones, which is the special lesion. In rosacea, there are never comedones. Number two, the background of a patient with acne is generally greasy and oily because there's increased sebum production in acne. In rosacea, you're going to have the presence of erythema and telangiectasia because the patient is flushing. It's a vasodilated response of the skin which is seen. And lastly, acne can not only be seen on the face, it can also be seen in the trunk, it can also be seen in the chest. So that time we call it as truncal acne. Whereas rosacea is strictly a disorder of the centrofacial areas. So these are the few points which can help us to distinguish between acne and rosacea. Treatment of rosacea in terms of topicals, we want to be giving metronidazole. In systemic drugs, we generally give doxycycline. However, for rhinophyma, we have to be using carbon dioxide laser. Next, you want to read disorders. First, you take up something called leukoplakia. Leuko means white. Onychia means means. So let's take up something known as Mbbs lines. Now, Mbbs lines are characterized by white transverse lines and they are associated with chronic arsenic poisoning. Second, we have Merck's bands. So Merck's bands are paired transverse bands, number one. Number two, the most important association of Merck's bands is going to be hypoalbuminemia. And then we have Lindsay's nails, also known as half and half nails. So here we can see the
arsenic measlines, hypoalbuminemia, Merck's band, Lindy's half and half nail. Chronic renal failure, liver disease, there is proximal 90 is white and 10, 50-50 kidney, 90-10 liver, 50-50 kidney, 90-10 liver. Okay. White nails, measlines, arsenic, hypoalbuminemia, paired bands, transverse paired bands, hypoalbuminemia. 50-50 white and brown is kidney, and 90-10 white and brown is liver disease.
proximal 50% is white and the distal 50% is brown. This half and half nail, the most important association is chronic renal failure. And lastly, in leukonakia, we have something called Terry's nails, where the proximal 90% is white and the distal 10% band which is there is going to be brown in color. So this characteristic nail is referred to as Terry nail. And out of many associations, one we need to remember for the exam is chronic liver disease. We now move on to the last topic in this module, which is going to be vesiculobullous disorders. So to understand this topic, we have to know two primary lesions, vesicles and bulli. The vesicles are fluid-free lesions which measure less than 1 centimeter, are called vesicles. If they measure more than 1 centimeter, we call them as bulli. How do we classify bullous disorder, students? They are broadly divided into immunobullous and mechanobullous. Immunobullous means it is going to result due to autoimmune process. Immunobullous disorders are classified based on the level of the split. The split could be in the epidermis, it could be below the epidermis, intraepidermal or subepidermal. Under intraepidermal, please remember students, we are talking about the pemphigus group. Under subepidermal, we have the pemphigoid group and the dermatitis herpetiformis. So in studying, always remember, this S should remind you that any pemphigus is always superficial. So any pemphigus word comes in the exam, the split is intraepidermal. Anything to do with P, which is P. So whenever you say pemphigoid, the D letter will remind you, and dermatitis herpetiformis also has a D. So deeper means the pathology is subepidermal. Now we go to the basics of pemphigus group. So the level of the bulla here is intraepidermal. The target protein is the protein which connects the keratinocytes together, which are desmosomes. And the process by which the desmosomes get ruptured, we already discussed it, it's called acantholysis. Now under pemphigus, we have to talk about pemphigus foliaceus and pemphigus vulgaris. Pemphigus foliaceus and vulgaris, both are immunobullous, both are intraepidermal, in both desmosomes are rapid. So these are the common features we need to remember. Now let us per se look at pemphigus foliaceus. In pemphigus foliaceus, the target antigen. That means inside the desmosomes we have antigen. The antigen which is implicated in pemphigus foliaceus is called desmoglein number 1. So please remember students, this one you should remember. From the letter F we can remember F for foliaceus, F for first desmoglein. Now this desmoglein number 1, where is it expressed in the skin? So here we can see through this beautiful picture that it's expressed mainly in the upper epidermis, below the stratum corneum. So upper epidermis below the stratum corneum is where it is mainly expressed. And what happens in pemphigus foliaceus is an autoimmune disorder. So the IgG antibodies are formed against the desmoglein 1. So they are going to target the desmoglein 1, which is connecting the diamond-shaped keratinocytes. This process is called as acantholysis. And during acantholysis, we already know that the cells are going to become circular. So we can see these are the acantholytic cells. And you're getting a blister over here. So when you get a blister, you see the roof is very thin. This is very, very flaccid. And the location of the blister is subcorneal. So always remember students that pemphigus foliaceus with a subcorneal blister, which has a very, very thin roof. And this desmoglein 1 is expressed in the oral cavity. But please remember, you see this picture, in the oral cavity, low concentration is desmoglein 1, high concentration is desmoglein 3. So by virtue of this, you can easily remember that desmoglein 1 is in low concentration in the oral cavity. That's why in pemphigus foliaceous, no oral lesions. This is very, 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 very important. And now we look. High concentration is desmoglein 3. So by virtue of this, you can easily remember that desmoglein 1 is in low concentration in the oral cavity. That's why in pemphigus foliaceous, no oral lesions. This is very, 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 very important. And now we look at the clinical features of pemphigus foliaceous. I just now told you there's a very, very superficial bulla. So you get transient superficial bullae. And these bullae, the roof of the bulla is so thin that it immediately ruptures, resulting in scales and crusts. So you can see this morphology. Scales crust morphology, it is called. And typically, the distribution of lesions, you can see, is referred to as seborrheic areas. So this is seborrheic interdistribution. So seborrheic areas are those areas of the body which are rich in sebum-producing glands. And lastly, please remember, I already told you, in the mucosa, there are no lesions in pemphigus foliaceous because desmoglein 1 is in low concentration in the oral cavity. And histopathology, you can identify, this is stratum corneum. You can see the subcorneal slit. So this is the stratum corneum.
એના દોવા દોડતો નથી અત્યારે ક્યાં રાખ પછી ઈ બાજુના જ બધા એવા થઈ ગયા ઓલી બાજુ લગભગ શોર્ટ પેન્ટમાં તો નહીં વાંધો હોય ઉભી રહે જાઓ જો આ જો શોર્ટમાં હશે ને તો પછી ઉભી રહે છે આમ જો તો ખરી પણ એવડા કપડા એટલે તો ખૂટતા નથી તમારે લેવાનું
હું ક્યાં કહું લેવાનું આવે કોકને એટલે સારા મોટા લેવા પડે જૂના ન થઈ જવું તો બધે થાય એવું ન મદદ થતા નહીં
આમાં કઈ રાખીએ તો ન ફૂગાવે એવું કઈ નહીં ઓલી ફિનાઇલની ગોળી જેવું કઈ
અરે આ બધું થાય એટલે આરામ જ ફૂગાવશે બીજા
અરે બધે આવે ફૂગી આખે આખા એના કપડામાં કે આખા આમાં એ આમાં તો બહુ હોય છે
છે